Alright, so I've got the topic of urinary incontinence, which is quite a dry subject to talk about, but not such a dry subject in reality for all of you that suffer from it. So I'm going to just go over things quite clearly for you, because about 3 weeks ago the Americans had a medical literacy week, which they discovered that pretty much no one really understands what doctors talk about when they get up and present, which is fair enough because we do tend to jabber on about things. So hopefully I can break this down and we all understand exactly what urinary incontinence is, why it happens when you have prostate cancer treatments, and what options we have available to us in New Zealand. So basically, the official terminology for urinary incontinence is the complaint of any involuntary leakage of urine. What that really means is you wet yourself. You leak, you have accidents, you've got no control, and when you got to go, you got to go. So it's quite cute when you're a child and you're learning to potty train, not so cute when you're an adult, and it's quite debilitating and socially isolating. How many of us in New Zealand suffer from it? Well, 20 to 35% of New Zealanders suffer from urinary incontinence. Approximately 5 to 8% of gentlemen, before they start their prostate cancer treatment, will have some form of urinary incontinence. That's 5% of people that go into treatment that already are wetting themselves occasionally or all the time. So you can imagine that's quite difficult for them when they start going through treatment because their rates of control are not as high, ultimately. So when we talk about continence and you look at your options, sometimes it's not something that's really discussed when you get that diagnosis of prostate cancer, because you've just been told you've got prostate cancer and you just want to know what to do. Quite frequently, incontinence and erectile dysfunction are very much brushed over, and that's simply because you're just getting through that whole concept of the diagnosis and where to next. So if we're talking about official rates, so with radical prostatectomy, the published rates are 2 to 15% of incontinence. External beam, 1 to 2, and brachy's 2%. We're talking about these ones. So these are the rates that we see quoted in the research papers. The reality is up to 40% of gentlemen who have a radical prostatectomy will be incontinent, so leaking urine. After external beam, it's up to 20%, and brachytherapy, it can be up to 30%. Why do people become incontinent? Well, there's a lot of factors that we look at, and as doctors, these are the sorts of things that we consider and we don't often verbalise. There's your patient factors. So have you already come with some incontinence? If you're already wet when you start your treatment, you're not going to be in that high group of not being wet at the end. So your risks of being wet at the end are higher. There's the cancer features and factors involved, what John was alluding to. When they go and do the surgery, if the cancer involves the nerves or the sphincter, then they have to take it out of premise for oncological control, because they're there to get rid of the cancer for you. They don't want to compromise cancer control for erections and continence afterwards. And then there's surgeon factors. As with anyone in the world, we're all different when we operate. We all have different experience, and often if you've got someone who's more experienced, they'll get better control of the cancer with better continence and erectile function results at the end. But why does the reality not match the figures that are published? Well, there's quite a few reasons. And this little picture I think is quite good. There's the story, there's the truth, and there's the perception. What happens with prostate cancer research is the people that publish the majority of the prostate cancer research are the people who do the surgery. So when you go and see your surgeon, often they'll forget to ask you about your continence. They ask you, are you wetting? You go, oh yeah, I'm a little bit wet. Or they ask you, how's the waterworks? And that's all they ask you. They won't ask you the real questions like, how many pads a day you're using? Can you get out of the house? Are you flooding your pants? Do you actually feel like you've got a decent quality of life now that you're sitting in pads all day? Or are you in diapers? And so the research is often published by people who do the cancer control. It really does play down the incontinence because they just don't ask the questions, because ultimately it's not something they're particularly enamoured with, which is fair enough because they're oncologists in their training. Also, patients don't tend to complain about their continence or incontinence. Sort of, you go to see your surgeon, he's just saved you from your prostate cancer, or your oncologist, and he's just saved you from your prostate cancer. You don't want to moan about something like wetting your pants because you feel a bit ungrateful. And so there's good research that shows that people just don't complain because we're not really given the opportunity to sort of mention it. So the windows or the pathways of communication are not open enough for us to talk about our wetting. And in society in New Zealand, no one talks about continence. No one talks about wetting themselves. It's a very taboo subject. We don't sit around the table and talk about, oh, I'm going through 5 pads a day. Oh, I've just bought those pads that are much better. You should try those. It's just something we don't do. So why does it happen? Well, this is a little picture. It's a very nice picture. So this is when they're operating. These nerves here are the nerves that they want to preserve. When they talk about nerve-sparing surgery. So nerve-sparing surgery is not just important for erectile function, but it's also important for continence control. In reality, it looks a bit more like this. So you can see there's no nice little yellow lines. It's all just a bit of a bloody mess, really. And so you can see sometimes it's not so easy to save bits and pieces. This is my experience of doing this surgery when I was training. It always looked a little bit like this. So these are the nerves. We want to save them, but sometimes they are damaged either intentionally because we have to take them during cancer control, or they're unintentionally damaged. They're removed, or they're bruised, or they're pushed so much they don't really crack on and get going again. This is the area where the sphincter is, and this also can be damaged, and this is also important in terms of control of continence. This picture shows another view, so there it is. So this is the prostate, this is your bladder, pubic bone here. This purple thing is the sphincter. So your sphincter is what you learn to control when you're potty training as a child. It's what stops you from wetting yourself. It's the muscle that they try and get you to squeeze when you do your pelvic floor exercises. So you can imagine when they are taking out your prostate or irradiating your prostate, it really is intermittently linked there. And so what can happen is it can be cut or it can be irradiated by accident. If this is irradiated or cut by accident, you're going to end up incontinent, unfortunately. The theory is when it's cut or removed, so this is the prostate, we put it in the bin, this is your sphincter, everything sort of slumps down, and so it no longer has the support or the ability to contract to stop you from leaking when you cough, sneeze, get out of your chair, put some washing on the line, mow the lawns, cut the wood, whatever it is that you want to do that involves any sort of exercise. Sounds dreadful, really, doesn't it? I'm not here to dissuade anyone from treatment, but I'm here to explain why we become incontinent, and actually there's a lot more out there than just pads. But unfortunately, as it stands in New Zealand, this is often all we're offered. It's pads, more pads, pads again, pads. And what I particularly like about the pads and the pad companies is everyone always looks really happy wearing pads, or diapers or pull-ups, whatever you want to call them. I'm pretty sure I don't know a single patient who's come to see me wearing pads who'd be running along the beach, looking that happy about life. So pads are not the long-term answer. We have a lot more options out there than are available just with these companies. Part of the problem is that these companies have a lot more money than we do as both the Prostate Cancer Foundation and the Continence Society in New Zealand in terms of making sure this information is well spread among the community. If you've been offered pads as your only treatment, now's the time to really listen up, because there is so much more, and it shouldn't be the only thing you're ever offered. All right? But why are they the go-to? Well, this is a pretty good cartoon actually that describes it. When you see your GP or your other doctors, I think, what was I like when I left medical school? How much did I know about continence? Absolutely nothing at all. And so there's a lot of general practitioners out there who will just refer you to see the continence nurses or your district nurses for a pad supply, pads or diapers. And the reason is they leave medical school and they've got no idea what we have available. And it really is a bit like this cartoon. You start asking them about continence or incontinence and they're like, oh, yeah, I wasn't good at geography. So there's not enough information across all the community, not just the general community, but also the medical fraternity, nursing fraternity, and also the DHBs are now, unfortunately, dumbing down our supplies. We used to have very good continence services, where you'd see the continence nurses and they do a proper assessment. Now, unfortunately, they're trying to make that just a pad service. So the reason I feel so passionate about this is that urinary incontinence isn't something that you should just put up with. It isn't just, one of those things, pull up your diaper and be on with it, get on with it, pull up your socks and get over it. It actually is independently related to falls, fractures, so we're talking about breaking our legs, isolation and institutionalisation. Patients who have incontinence are more likely to fall And that's not just slipping in the wheeze on the ground, but those that are rushing to the toilet because they know they can get there if they get there and they fall on the way. They're more likely to fracture their hip. Now, fracturing your hip when you get a little bit older is a prime indicator to institutionalisation in the next 3 to 4 years. So once you start breaking your hip, it's not a good sign. Isolation, people who are wet often just can't get out of because they're embarrassed. They're wearing diapers, it's difficult to manage, they're worried they're going to leak through their diaper or their pad, so they become socially isolated. You're more likely to be placed in a rest home or a hospital or institutionalised in some form if you have urinary incontinence than any other medical illness. So these, although we joke about incontinence, these are quite serious repercussions of being wet. So the goal really for any incontinence control is to get you down to 1 pad a day. The reason for 1 pad a day is what we call a just-in-case pad. If we get people down to 1 pad a day, we give ourselves a pat on the back. We think we're doing pretty well. All right. And when should you start that? Now, last time I did this meeting, I had gentlemen come up to me afterwards saying they had their radical prostatectomy 5-10 years ago, and the surgeon had said, "Oh, we're not going to start treatment for your continence for another 2 or 3 years." All right, that's not great. You need to start your continence control immediately after surgery with your pelvic floor surgery exercises, but you need to look at having an operation or an intervention after 12 months, because by 12 months you either have return of your pelvic floor function in your sphincter or you don't. When it comes to your radiation damage, radiation has this amazing way of letting you cruise through the first 3 to 4 years after treatment, thinking everything's tickety-boo, and then it comes back to bite you, so to speak. With radiation, when you start treatment for continence, so once we know that the radiation damage has stabilised. And that sort of has to be looked at on an individual basis. The key thing, I think, for a lot of people is they're told that there's no way to get this funded. Urinary incontinence post a radical prostatectomy in New Zealand is still considered a treatment injury, so ACC will pay for your treatment. The key thing here is ACC will pay for your pads. If you apply for ACC, it's accepted, they'll pay for your pads and your diapers until you can come forth and have more definitive treatment. So it's something to bear in mind, because all these treatments can end up quite costly, and there is this way that we can fund it in New Zealand. A lot of DHBs now take it more seriously in terms of placement of sphincters and slings, which I'll show you later, because there's a few more of us across the country that are interested in it. So you shouldn't be put off, you shouldn't be told that there's no one around that can manage this for you. So if your GP says no, just keep on asking, keep on knocking on the door, contact Prostate Cancer Foundation, and they'll be able to head you in the right direction. With radiation, there's more radiation claims that have been accepted probably in the last 6 months than there was in the last 6 years, because there's a greater understanding that radiation is what I refer to as a gift that keeps on giving, because you can, as I said before, cruise through your first 3 to 4 years, but radiation keeps on destroying good tissue after it's done with destroying the cancer tissues. Now, it's a great way to get rid of cancer, but it's indiscriminatory in terms of the tissues that it affects long term. So it keeps on giving us a few problems later. So as a reconstruction surgeon, it keeps me in business, basically. Treatment of urinary incontinence is completely determined by the type of incontinence that you have. You don't want to be having surgery if you don't have stress incontinence, and you don't want to be having medications if you've got stress incontinence. So going forward, the type of incontinence you can experience is, so this is normal, your bladder is full, your prostate's there, your sphincter's there, there's your urethra, you're not leaking. Stress incontinence is when you have no prostate, mostly for men, and you get pressure on the top of the bladder and it just starts to leak out the bottom. Urge incontinence is when you've got an overactive bladder, so your bladder's contracting all the time and pushing the wheeze out. And overflow incontinence, which doesn't happen too frequently, fortunately, is just basically your bladder's too full and it's just spilling out all the time. So stress incontinence, breaking it down, is just coughing, sneezing, laughing, jumping on the trampoline, cutting your wood, mowing the lawns, all those sorts of things where your abdominal pressure is higher than your sphincter pressure. So you end up leaking. Quite commonly, it's the sort of thing that you see ads for ladies where they laugh and giggle and cross their legs. But basically, all the exercises end up with you just sitting in a puddle of wheeze. Urge incontinence, that's when you've got to go and you've got to go. You cannot defer it. That's the sort of, I describe it as the wiggle dance that everyone does as they go to the bathroom. They're sort of crossing their legs and hoping they'll get there in time. So that's your bladder contracting before you can get there, and it's contracting harder than it should. So it's not really meant to do that, but basically it's contracting and pushing the urine out, just like this cat. So first and foremost, everyone should be having pelvic floor rehabilitation. As soon as you've had your surgery or you've had your diagnosis or you've decided on what sort of management you're going to have, your pelvic floor rehabilitation should be something that you're referred on to start. Pelvic floor rehabilitation does quite well, and then the other conservative treatments are clamps. So pelvic rehabilitation is best done with a physiotherapist who actually specialises in this. There's good research that shows that if you do this with someone who's passionate about pelvic floor and they've got you doing your Kegels 6 or 7 times a day, and you're squeezing so tight you could pop out a diamond, you will have a 30% better result than someone who's just doing it by themselves, or you've looked something up on YouTube. So if your services in your areas have a pelvic floor physiotherapist that you can get to, use them. If they don't, there's something called steel physiotherapy, which is a physiotherapy program that's designed for gentlemen who have who have had prostate cancer, for you to be seen by someone who specialises in pelvic floor physio for free to help you with your recovery. So it's definitely worth contacting those people and getting those details. With your pelvic floor physio, you'll have a faster return to function. What it means is that if the surgery's gone well, or the external beam radiation or your brachytherapy's gone well, your physiotherapy will allow your function in terms of your sphincter control to come back faster than it would if you just waited around for nature to take its course. Clamps. Now, I presented these clamps recently at an international meeting with a whole bunch of urologists, and they all roared with laughter. Because apparently we're about one of the only countries that still use these sort of prehistoric torture devices. This one here is a modernised device because it's got a bit of foam, but the premise behind a clamp is that you put it on the end of your penis and basically you squish it so the wheeze doesn't come out. I don't like them, and I don't even have a penis, so I think they're a bad idea. They do work. But there's lots of reasons I don't like them, including the fact that sometimes gentlemen just leave them on and then when they finally remember to take them off, the skin can break away. Not good. And really, this is not a good answer. This to me is up there with pads, you know. This is just basically a crutch to get you through a period until we can get something better. But these are still offered left, right and centre in New Zealand. Apparently nowhere else, which is somewhat embarrassing when you put it up at an international meeting. So urge incontinence, so this is the cat that was rushing off to the toilet. So with urge incontinence, our first line is always medications. We have oxybutynin, selenoepicid and tolterodine available for us in New Zealand. Oxybutynin can be prescribed by your general practitioner. The following two do require a specialist authority from a urologist like myself or John. The whole idea of these medications is to stop that urge. So when you do need to go, you don't have to do the wiggle dance down the hallway to get to the bathroom. It allows you to defer going. So you shouldn't have as much urge, you should have decrease of frequency of going, and also you should have less urinary incontinence associated with that, so less leakage on the way to the bathroom. These are quite good medications, they've been around for a long time. They have some side effects, as with everything unfortunately, and one of the side effects is it can give you quite a dry mouth. One of the other ones it can give you is constipation. And one of the ones that are coming out, and a little bit more information has been developed on it, is cognition problems. So there is some evidence that shows that if you take these for any length of time, so longer than 3 years, it may make you a bit more muddled than you were before. Maybe an okay thing if you don't want to know what's going on. Maybe it's not such an okay thing for your family members taking care of you. If you try the medications and actually they're awful, you don't like the way they dry out your mouth, you just feel muddled on them all the time and you can't get out of the house because you can't remember where the keys are, or they give you such bad constipation you don't really know what to do, you can go into Botox. So this is not the Botox that we put into people's faces. We don't do faces. If your urologist suggests that they can make you look more youthful by putting in your face, you could be a bit worried. But we put it into the bladder. It's obviously not her bladder. And we've been putting it into the bladder in New Zealand for well over 10 years now. So the Botox in the bladder works just in the same way as it works into your face. It makes your bladder look really pretty. No one gets to see it except us. No, what it does is it stops those contractions that we were talking about, where your bladder's contracting when you get the urge, and it's contracting so hard and so fast that you're leaking trying to get to the bathroom. What it does is it stops those extra contractions, so then you have the time to get to the bathroom. You don't have to rush. So again, you'll have decreased urge, decreased frequency, and decreased urinary incontinence associated with the urge. Botox is fantastic. I think it's a great drug. It does have to be placed by us going up through the eye of the penis, so we can do that under an anaesthetic, be it local or general. Lasts 6 to 9 months before it starts to wear off. When it wears off, you just will find that you have to rush to the toilet again, and then it can be replaced again. This is offered in all the DHBs in New Zealand, so there's no reason that no one cannot access it. It's available under the DHBs and the health systems. It's only, I guess, one of the side effects that people talk about a lot is urinary retention. It can work so incredibly well that you can't pee. That happens in about 3% of people if we get a little carried away and we give you a massive dose, like this person's obviously had for their face. And then there's sacral nerve modulation. So sacral nerve modulation is relatively new to New Zealand, but it's not new internationally. So to give you an idea, they've been placing this for about 10 years in the States when they weren't using Botox because they didn't have funding through their medical insurance companies for Botox overseas, but they had funding for this implant. So this is again for someone who has the urge and urge incontinence. This is a great little device. It looks a little bit prehistoric, but the whole idea is that you put this lead in through your S3 foramen. So it's a little metallic lead that gets put in under an anaesthetic into your back, so down in your sacrum, which is down the back of your spine. You have it placed, and then for 2 weeks you wear a sort of 1980s fanny pack with a little battery, and we work out whether or not it works for you. If it works, after 2 weeks, you have this battery placed in the upper part of your buttocks, and then you get a little remote control for it. And this is basically a pacemaker for your bladder. The whole idea is it removes your urgency, so that rushing to the toilet, removes the frequency, so that sort of having to go to the toilet all the time, and the associated incontinence with it. The battery lasts for about 7 to 10 years. When you need it replaced, we just whip it out and put another one in, just like the batteries at home. The problems with it is you can't have lots and lots of MRIs. And with MRIs becoming more important in prostate cancer, ongoing management and follow-ups. But it really depends on what sort of treatment you've had, what sort of prognosis they have for your prostate cancer, and whether or not you're going to need more MRIs. Other problems with that is that the DHBs don't fund it. And this is the biggest rate limiting step in New Zealand, otherwise I think I'd be putting more of these in. So the device in New Zealand all up costs $22,000, which is a lot of money. It's currently being used for fecal incontinence, which is its last indication internationally, and hopefully in the next 18 months we will actually get some funding for it to be used for the bladder as well. But it all depends on how well promotion of it goes. So stress incontinence. So stress incontinence is when you're coughing, you're sneezing, you're standing up, you're mowing the lawns and you're leaking. Or someone tells you a good joke and you leak. So the gold standard of managing stress incontinence post-prostatectomy is the artificial urinary sphincter. So the artificial urinary sphincter is actually older than I am. It was invented a while ago. And it's a 3-pump system, similar to the penile prosthesis that John was showing us. Now, this is the little pump that sits in your scrotum. I like to call it your third testicle. There's a little reservoir that sits in your abdomen that you don't know anything about, and then there's this lovely cuff that sits around your urethra. And this is a different view of it. The whole idea is that when you need to wee, so you get your normal sensation that you need to go for a wee, you go to the bathroom, you push on your pump, which is your third testicle, the fluid comes out because it's compressing the urethra when it's activated. So the urine can't come down, so it's squishing it basically. And then when you go to wee, the fluid comes out, it goes into the reservoir, and then as you're weeing, it comes back in and it turns itself off. As I said, these have been around for well over 40 years now. They've been slightly modified since they were first invented. They too, because they are hydraulically based, they have problems in terms of sometimes they run out and they need to be replaced. Occasionally people have them placed and they work really well for the first year or so, and then they start leaking again. Normally what that means is that your cuff has to be replaced. But generally speaking, these are really good for gentlemen who have more than 3 pads a day in their needs for their continence. So if you're wearing diapers or you need more than 3 pads, then you probably need a sphincter. You do have to remember to use it, that's the problem. If you think you're not going to remember to push on it, then it's probably not the thing for you. Or if you don't like the idea of having hydraulics in the body, then it's also not a good thing. These can be placed at the same time as the penile prosthesis, so then you end up with 4 testicles. It's a good idea not to get them muddled up. So for gentlemen who are less wet, or don't like the idea of having something they need to squeeze, or have got a little bit muddled and can't remember to squeeze, slings are quite a good idea. So there's a few more slings on the market than there was even a year ago now. So this is the Colplast sling, so it's called a Virtue sling, and it's got 4 arms to it, but the whole idea is it squishes the urethra and supports it here. You can see. And the whole idea is that it lifts up where, if you remember that picture, it looked like everything had sort of sunk down after surgery. So it lifts and compresses. So when you cough and sneeze, it holds it in place so you don't leak. This is the Advanced one from a different company. Same premise, sits in the same area and sort of pushes it up. This one is a new one called the Atoms. So this has got a little water-filled container there, and a little area up here that you can punch in with a needle from the outside to fill up if you start leaking. So you can see they're all put in the same place anatomically, but they've all got slightly different ways that they're managed. So with this one, we have it put in, and then this little reservoir we can palpate underneath your skin and puncture it like you would for a blood test and put more fluid in as and when we need to. I like this one. I've never put it in, but I think it's hilariously funny. This is from a Spanish company. It's called a Remix. It's an adjustable sling. So again, mesh that goes around the urethra. This goes just above your pubic bone. And you see there's just a little screw thing there. So you'll see what happens is, when you have this in place, the next day we put a little screwdriver in here and tighten it for you till you can't cough and leak, but you can still pee. You go off, you do your thing for a couple of months, you come back, we put a little screwdriver in and tighten up it again. Great. And the new frontiers, well, in terms of, because obviously all of these things are ways to manage it, not ways to cure their incontinence. So there's new people who are thinking about doing what we call nerve grafting at the time of surgery. So nerve grafting is, if you remember back to that picture where it had the nice yellow pictures of the nerves, so whenever they do anatomical diagrams, they always make the nerves yellow. But then you'll remember that picture I've showed you what it really looks like. There ain't any yellow in there. But the whole premise behind nerve grafting is that at the time of surgery, should the nerves be cut, that they are able to basically stitch them back together. Because with the advancements of medicine, we now understand that nerves do repair themselves a bit better than we initially thought they did. And so the idea is if they can stitch those nerves back together or use a different nerve as a sort of accessory nerve to bring it across, then you might get better functional return of both your continence and your erectile dysfunction or function. So the whole idea, this is my picture again, is that if it gets cut, then they stitch them all back together using additional nerves that are just hanging around. The results haven't been great because they're doing it at the same time as surgery, so you can't really be sure if this is going to work because they need to sort of do it at a different time. You need to have your surgery and then they need to go back and nerve graft. But in reality, that sort of bloody mess that you saw will be even more bloody if we try and do it at a different time. So I'm not sure how well this will take off.